Alright, so good afternoon. I just want to thank y'all for being here today. I'm sharing what we learned in phase 1 of IPOP, which is an independent practice operations pilot. This is a systems investigation into why independent practices are struggling and what we might do about it. Here's how we're going to move through this. I'm going to start by reframing the problem, walk through what we actually saw in phase 1, and show the key friction patterns and workflows we mapped, and talk about where this naturally leads for us in phase 2. So the biggest insight from phase 1 is simple but important. The main friction in independent practice is not clinical, it's systemic. Clinicians are spending an enormous amount of time and energy on insurance paperwork, prior authorizations, denials, and administrative tasks that pull them away from the patients. These pressures don't start in the practice, they come from upstream policy, reimbursement rules, financial structures, and supply chain issues. So this didn't begin as a system study. It began with a clinical tool. I was building a shape matching device. And through clinician interview notes and cybersecurity reframe, we identified the underlying issue, and this was identified by Dr. Aradine. He said it's a bunch of bureaucratic nonsense. Another clinician said the textbook don't mean nothing when real patient needs collide with insurance. What with insurance will actually pay for it. Those conversations made it clear we need to understand the system first before trying to build anything. So the phase 1 was funded by the Levitens grant. It was all about observation. We focused on direct clinician engagement and real world shadowing instead of assumptions. From that work, we produced 3 concrete deliverables: a healthcare friction map, a full practice workflow analysis, and administrative and denial taxonomy. So phase 1 defined and explored friction. We identified revenue cycle management, insurance credentialing, prior auth and appeals, and payer communication as the main issue points that phase 2 can solve. Phase 2 is going to aim at constructing software that manages these revenue cycles and build it in a sandbox environment with simulated patient data. And we may consult with Teddy Tech over there and see if we can get into real patient data. So the healthcare friction map shows 7 consistent pressure points that kept appearing across practice. We have insurance complexity, heavy documentation burden, and frequent claim denials that pulls clinicians away from the chair. So the important point is that it's not any one of these things, it's that all these pressures are connected and they're coming from outside the clinical workflow itself. So, to see where this friction actually hits, we map the full end-to-end workflow of independent practice, from patient flow to documentation to billing and supply ordering. What stood out is that the clinicians is hands-on all day, or whether they're hands-on all day or running more of a practice manager model, the same bottlenecks keep showing up. This tells us that it isn't about individual style, it's about the system itself. So, administrative and denial taxonomy. These are the main reasons that claims get denied by the insurance companies, and it's a rapidly changing environment in terms of the coding that you do when you're trying to code for the insurance claims. So these are predictable outcomes, how current insurance and the reimbursement system is designed, and things that phase 2 will come to fix. So the chartering and first deployment of IPOP is in my father's multi-specialty building. Orthopedics, dialysis, ENT procedures, and physical therapy all under one roof. This setting contains the exact insurance and supply chain frictions we've been mapping, and it gives us a real controlled environment to charter IPOP as an in-house parallel support layer, testing shared non-clinical health while fully protecting clinical autonomy. Phase 1 showed us that the friction is connected to much larger forces: healthcare policy and financial structures like REIT, real estate investment trust, ownership, and phase 2 will be operating right at that intersection. Like Dr. Adams, I also took a trip to DC over spring break and met with the risk management consultant for the Capitol and talked to him, and he introduced me to the founder of his consulting firm. And we identified healthcare as being a big supply chain management. Healthcare as being a big issue that is going to be changing here in the next 10 years, and we want to figure out what we can do to be in front of that game. So the grant money given to us by Mr. Levitats was used very deliberately, mostly for direct shadowing and clinician engagement, with some support for policy expansion in Washington and tools to help synthesize what we learned. Every dollar went towards building real and grounded insight. So how an additional $500 would affect us, it would allow us to deepen the same work in the same focused way, more targeted shadowing, stronger supply connections, supply chain mapping, to better understand how external shocks hit independent practice. We'd be able to test this software in a sandbox environment using Amazon Cloud Systems, and discuss. We may consult with Teddy Tech to discuss more security risks before proceeding. So, phase one, identify the operational friction in independent practice is systemic. It's reoccurring and sits at the intersection of insurance policy, financial structures, and supply chain pressures. Phase one has given us clear artifacts and a strong foundation to move to phase two with focus. Before we open for questions, I want to say who this work is really for. Independent clinicians who buy their own building aren't just running a business, they're building a family legacy. Across every interview, we heard the same thing. These are good people who constantly choose to do the right thing for the patient, even when it costs them financially. My father, an orthopedic surgeon, once said with tears in his eyes, "I love my job because I have the opportunity to help people, even if they can only pay what they can when they can." That's who Mr. Levitats is helping, good people who do things the right way. So, as we move into open questions, these are some questions that we're still investigating. Where can local practice needs interface effectively with upstream policy and supply forces to create meaningful change? How will accelerating supply chain reshoring and real estate investment trust activity affect long-term stability of independent practices? We saw during COVID, large systems got early access to supplies, so like the UAB network got early access to supplies, while independents were pushed into secondary markets with huge markups. In dentistry, entire segments, about 70% of dentistry didn't even happen because it was considered non-emergent and they didn't generate enough revenue to even be able to continue running the practice. So it raises a deeper question. Can we build regional or state level infrastructure like shared warehousing to protect independent providers next time? And where exactly does IPOP fit in that picture? I envision navigating supply chain reshoring as well as procurement strategy. And I wonder what Mr. Levitat's advice would be for me given his background in supply chain management and procurement strategies. And I wanted to thank you for your time and support. I'm happy to take any questions. This is my business card. It'll send your contact to my phone and give you my contact as well.